بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we'll start a new series about imaging of the urinary system, and we will inshallah cover most of the aspects in this domain concerning the renal pathology, ureteric lesions, urinary bladder pathology, urethral abnormalities, prostatic lesions, and also we'll cover the scrotal and testicular pathology, inshallah. Now we'll start by the first part of the renal imaging. It is comprised of three parts. In the first part, we'll deal with congenital anomalies and renal stones. Then we'll continue by the renal infection and trauma. Then after we'll discuss the renal neoplasms. As you all know that we have too many imaging modalities for evaluation of the urinary system, including the plain radiograph, the intravenous urography, the cystography and urethropy, abdominal and pelvic ultrasonography, nuclear medicine studies, the CT, MRI, and some of the interventional techniques. Then the plain UT or the KOB is considered one of the simplest procedures for evaluation of the urinary tract, and it may require some preparation to clean the food residue in the colon so that we are able to see the renal area, the ureteric course, and the urinary bladder. The diagnostic value of this imaging modality include the detection of radiopaque calculi, the detection of calcium, assessment of the gas pattern. Sometimes we can see enlargement of the liver and the spleen, and also we should look for any abnormalities in the skeleton which may be associated with the renal or urinary tract abnormalities. And these are examples of urinary stones, small renal calculus in the lower pool of the kidney, the staghorn calculus, and this is another example of a staghorn calculus. And this is an example of two radiopaque calculi outside the renal shadow, indicating that they are present in the gallbladder. And this is heterogeneous calcification of the renal parenchyma, what we call nephrocalcinosis. And mottled calcified shadow in the female pelvis is usually due to calcified fibroid. Dense calcification along the course, the anatomic course of the pancreas, are diagnostic of chronic pancreatitis. Calcification of the gallbladder wall is diagnostic of porcelain gallbladder, which carries the risk of 30% malignancy. Then, considering the gas pattern, if you see that the bowel loops are dilated, then you in the supine film and you have the erect film, and you can see multiple air fluid levels. This is an indication of the presence of intestinal obstruction. Also, if you see multiple fluid levels in the colon, and you know the colon by its characteristic rostral pattern and the peripheral location in the abdomen, then you consider it colonic obstruction. And the most common cause of colonic obstruction, usually in elderly, is malignancy. And this is what we call an apple core configuration in the sigmoid colon, diagnostic of sigmoid carcinoma, which is responsible for this obstructive pattern. Then the plain film also can identify intraperitoneal air, which is known as pneumoperitoneum, and this is best appreciated by the chest X-ray in the erect position, where you can see air under the diaphragm, either unilateral or bilateral. But if you cannot image the patient in the erect position, and you can have the supine plain X-ray of the abdomen, and if you are able to see the bowel wall, and this is known as regular sign. Regular sign means that there is air outside the bowel, and also there is air inside the bowel, and that's why you are able to see the bowel wall. Normally you cannot see the wall of the bowel as you can see here, but you can see the gas inside the bowel. Then if you are able to see the wall, and this is an indication of pneumoperitoneum in the supine film. This is an example of how splenomegaly looks in the plain film, and this is also an example of hepatomegaly in the plain film. Also, the plain film is helpful in identification of radiopaque foreign bodies, and it can follow the course of the foreign body until it goes outside the body. Intravenous urography is one of the primary imaging techniques used for evaluation of the urinary system. It usually requires some preparation and good hydration of the patient, and also the patient should fast for about 6 hours if he is an adult, or 4 hours for children, and he should have also the renal function test, especially the serum creatinine level, which should be below 1.5, not 3 is written here, 1.5, so we are able to inject the contrast material. We use usually the non-ionic contrast media, which are less harmful to the kidney. Of course, you know that there are two types of contrast media injected intravenously, the ionic and the non-ionic types. And non-ionic contrast media are relatively expensive, and but they are safe for somewhat safe for the kidney compared to the ionic contrast material. The diagnostic value of intravenous urography is to show the renal function, and also to detect an obstructive lesion, to see urinary tract obstruction, and many times you can identify the cause of obstruction. It can also help in identification of renal and urinary bladder masses, as well as ureteric masses, as we can see. Also, it's very important examination in evaluation of the congenital anomalies of the urinary tract. There are two main obstacles for injection of contrast material. These are the poor renal function and the hypersensitivity of the patient to contrast material. Then whenever you inject contrast media, and before injection of any contrast material, you should have the plain film for the urinary tract to be sure that the patient is adequately prepared, and to look for radiopaque calculi that can be obscured after injection of contrast material. Then you inject the contrast material, and take a series of films spaced every 5 minutes or 10 minutes, according to the kidney function and the secretion of contrast by the kidneys, as seen in the first film. Then you have another film to see the ureter, and later on you can get another film for the urinary bladder. Sometimes we perform what's known as nephrotomography. It's a conventional technique where you can remove the superimposed gas shadows on the kidney, so that you are able to see the renal outline, and you to judge about the renal parenchymal thickness, the renal contour, and also to see the pelvic ileal system. And nowadays there is a technique which is known as digital tomo senses, which is exactly similar to that used in the breast imaging. And by this tomosenses, we mean that we have tomographic views, but computer aided. Then if you look here in these, you can see that there are a lot of gases in the abdomen of this patient, obscuring totally the left kidney and partially the right kidney. And here in the DTS, or the digital tomosensors, you can appreciate the normal appearance of the right kidney and also the normal appearance of the left kidney with adequate delineation of the pelvic ileal system on both sides. And this is another example where you can follow the secretion of the contrast material by the kidneys, also by tomographic views. And here is the early phase. Then you got by time you got opacification of the collecting system. Finally, you should have a film for the bladder where it is filled by the excreted contrast material, and we have oblique views for the bladder as well to see if there are any compressions or indentations. After that, you let the patient evacuate the bladder and look for the amount of residual urine. The cystohysterography will be discussed in details in the talk about the urethral pathology, but this is one of the basic imaging techniques used and is still used up till now for delineation of the urethra. And this investigation is very good for evaluation of urethral pathology, and also it can be used to assess the presence of vesicular reflux, and sometimes in evaluation of stress incontinence. Then the items that we are going to evaluate considering the kidney. Number one, the congenital anomalies. Number two, the stone disease. Then we'll discuss actually the renal trauma and the infection. Then we will discuss later on the pathology of renal masses. And after that, we'll have some issues about the miscellaneous pathology. Considering the congenital lesions in the kidney, there are a lot of congenital lesions, starting from absent kidney or renal agenesis, hypoplastic kidney, malrotated, duplex kidney, ectopic, horseshoe, congenital pelviureteric junction obstruction, congenital megaureter, urethrocoel, and the calyceal diverticulum. Agenesis of the kidney means that it's known as monorenal patient, and bilateral agenesis is of course incompatible with life. Then in cases of agenesis, you are not able to see any renal tissue along one side of the body. And hypoplasia means that you got a small kidney that may or may not excrete contrast material. Here is the renal agenesis on the left side. You cannot see any renal tissue or secretion on this side, and also it was confirmed by isotope scan. And here you see the right kidney with normal course and caliber of the right ureter, and you got some reflux of this blunted terminal part of the left ureter. And this is the right-sided agenesis with normal left-sided kidney and ureter. And here you got the solitary pelvic kidney on the right side with absent kidney on the left side. The right kidney is ectopic, is solitary, and is hydronephrotic as well. And this is the CT scan showing solitary left kidney with absent right kidney. Of course, the solitary kidney will be somewhat enlarged, which is known as compensatory hypertrophy to compensate the function of the absent kidney. Then you may see the kidney, but it is of course smaller than normal than this kidney. As you can see also in this another example, a smaller right kidney with normal or hypertrophied left kidney with duplicated pelvic ileal system. And in this example, you see a small left kidney with reduced renal cortical parenchymal thickness. And this is also a normal sized or hypertrophied left kidney containing a simple renal cyst. And this is a small right kidney which shows adequate contrast excretion. The differential diagnosis for a small kidney include the hypoplastic kidney, the post-obstructive atrophic kidney, and the kidney with chronic pyelonephritis. Then malrotation means that the direction of the pelvic ileal system is not as usual, and here you may have many forms of malrotation. What's important is to look if there is any associated obstructive lesions or stones or even tumors sometimes. And this is normally positioned left kidney, while the right kidney is malrotated, and you got the bizarre appearance of the calyces and the renal pelvis. By CT, the renal hilum should look medially towards the spine. But in this case, you can see the renal hilum is pointing anteriorly on both sides, indicating bilateral malrotated kidneys. These are normally positioned kidneys, and these are bilateral malrotated kidney with the renal hilum and renal pelvis facing anteriorly. Then sometimes you got the renal contour is normally smooth, but if it is lobulated like this without any associated disturbance of the corticomedullary line, and this is known as fetal lobulation, which is a congenital variant. And many times you can see that there is a bulge in the renal contour, and the calyx corresponding to this bulge is going through the bulging renal outline. And this is known as dromedary hump, and it is also a congenital variation, and it should be carefully discriminated from renal tumors or other abnormalities. Then if you look here, and you can see a dromedary hump, and the calyx is pointing through the renal tissue. This is an example of the normal variant, which is known as fetal lobulation of the kidney. The renal parenchymal thickness is good, the calyces are not dilated, and the renal function is maintained. This is normal variant. And this is by ultrasound and by IVB, where you can see what is known as dromedary hump, where the renal cortical outline bulges beyond the renal contour, and the calyx is also bulging towards the hump. Another example where you can see this hump in the kidney is well delineated by ultrasound. Sometimes it's difficult to be seen by IVB. Then the ectopic kidney means that the kidney is not at its normal location. The most common site for ectopic kidney is the pelvis, and many times you can overlook this kidney either during IVB or ultrasound sometimes, but be careful about this well-known congenital anomaly. In this plain UT, then you can see a stone superimposed on the sacrum. It may be in the ureter of the left kidney, but the IVB showed that the kidney is ectopic, and this is the stone which is located at the renal pelvis. It is also malrotated and hydronephrotic. And this is an example of bilateral ectopic pelvic kidneys by CT scan. Sometimes the kidney is crossed to the opposite side, but it is always drained by the ureter to its original site, meaning that if the left kidney uh, crossed the midline to the right side, its draining ureter will enter the renal bladder from the left side. Then one of the common congenital anomalies is known as horseshoe kidney, where both kidneys are fused across the midline, forming what looks like a horseshoe. And many times in the radiology books, they call this the flower vase appearance. Mean you can see that each kidney represents one of the flowers, and that they are uh, as if they are in a vase. And the collecting system sometimes is malrotated, sometimes is dilated, sometimes is obstructed. Then this is the appearance of horseshoe kidney by CT. Both kidneys are fused across the midline, sometimes by functioning renal tissue and sometimes by fibrous tissue. And this is the coronal CT image, coronal reformatted image showing the two kidneys fused across the midline. Then we came to the urethral malformations. We'll discuss this in details in the part dealing with ureteric pathology. And the most common abnormality will affect the ureter is its duplication, which is seen in more than 0.2% of autopsies. And the duplicated ureter may be partial or complete, and you got two separate ureters entering the urinary bladder in two different openings. And this duplicate ureter, one of them will enter in an abnormal location, and it may be associated with other congenital anomalies like urethroceal, for example. Then the mild form of duplication is known as bifid renal pelvis, where you can see that the renal pelvis is divided into two, but the remaining part of the pelvis is solitary, and it's also drained by a single ureter. And here you can see that the helices are within normal configuration. Then this is partially duplicated kidney and ureter, and you got two moieties, upper moiety and lower moiety, and drained by two ureters, and the ureters are fused near the pelvic inlet, and they form a single ureter entering the urinary bladder. But sometimes you can got two ureters that are running separately, entering the urinary bladder in two separate openings. And this will result in abnormalities in the drainage of one of the moieties, which is most commonly the upper one, where the ureter draining the upper moiety usually enters the urinary bladder or has an ectopic location, like in the bladder, but in an abnormal site, or the urethra or the vagina sometimes. And this will result in abnormal drainage of this upper moiety, which will become hydronephrotic, and the ureter is also dilated. This many times is seen that the upper moiety is that will suffer from obstruction and abnormal drainage. But in this example, and you can see two moieties on the right side. The upper one is good, and the lower one has a congenital pelviureteric junction obstruction, which will be explained later on. And this is after surgery for correction of the obstruction. And 3 months is post-operative, and you got somewhat resolution of the obstructive changes and regression of the dilated helices. And this is duplex kidney on the left side. The lower moiety is good, the upper moiety is dilated, the ureter is markedly dilated and tortuous, and it has an ectopic location entering the urinary bladder. The ureter may have an ectopic end in 7% of the cases, and this ectopic end may open into the bladder neck, the posterior urethra, the seminal vesicle, the vas deferens, the vagina, the cervix, or the uterus in women. Then another abnormality, which is also the sequelae of duplication, where the upper moiety is obstructed, hydronephrotic, and non-functioning. Then you got enlargement of the upper part of the kidney, compressing the normally functioning lower moiety, giving this typical appearance, which is known as the drooping lily sign or the drooping flower sign. Then if you see this appearance, you expect that this upper part of the kidney contains another pelvic cell system which is obstructed and non-functioning, compressing the lower moiety. And this is by CT scan where you can see the, the, the lower moiety is good and the upper moiety is hydronephrotic. The ureter is hugely dilated and it ends by this which may represent in a stone obstructing the upper moiety. And this is also another example where you wait for some time until the upper moiety secretes the contrast material. This is the lower moiety, which is good, and the upper moiety is hydronephrotic. The ureter is markedly dilated and tortuous. And you see the ureteric course along its whole part. And you may have the 3D reformatted images where you can see the upper moiety, the dilated hydronephrotic moiety, and the normal lower moiety. And erythroceal means that the terminal part of the ureter is dilated and cystic or cystic dilatation of the terminal part of the ureter, and this may be due to congenital obstruction of the ureteric orifice, which may be related to a defect in the reabsorption of the membranes at the terminal part of the ureter. It is relatively common in women, and in 10% of the patients, it is bilateral. The association between ureteric duplication and erythroceal is in the range of 80% of the cases. Sometimes the erythroceal may result in megaureter and hydronephrosis, and in adults it may not cause obstructive changes. Be careful that the erythroceal, whenever it is not filled with contrast material, it will appear as a filling defect in the urinary bladder. And this should not be mistaken for a tumor or a radiolucent calculus, for example. This is the erythroceal before being filled with contrast material. It has a very smooth, sharp margin and uniform radiolucency. And if you look in the ultrasound, this is the appearance of the erythroceal, and the CT scan, and this is the appearance of the erythroceal. Whenever the erythroceal is filled with contrast, it will simulate the cobra head. And this is the ureter, this is the erythroceal, and this is mucosal edema surrounding the erythroceal, hence the simulation between the cobra head. And these are the two examples for the erythroceals. This one is not filled with contrast material, and this one is filled with contrast material. Another example of a small erythroceal on the left side. Maybe there is another one on the right side with mucosal edema surrounding the erythroceal. And megaureter is a dilatation of the ureter, either a part of the ureter or the whole ureter, due to malfunction of its terminal segment. It may simulate the achalasia of the cardia, where the urine is not evacuated adequately through the ureter due to disturbance of the function of the terminal part of the ureter, resulting in abnormal stagnation and stasis, which is followed by dilatation of the distal part or even the whole part of the ureter. And there are some classification of the types of the megaureter. Type 1A, the distal part of the ureter is dilated. Type 1B, the whole ureter is dilated and the calyceal system is intact. Type 2, the whole ureter is dilated and the calyces are also dilated. Type 3, the ureter is dilated and tortuous with dilatation of the pelvic calyceal system. And this is type 1A mega ureter, where the distal part of the ureter is dilated, but it's also bilateral. You can see here. You can see that the proximal part of the ureter is not dilated and the calyces are within normal configuration. And here is the CT scan of the same case, where you can see dilatation of the terminal part of the ureter, but the calyces are within normal. And this is another example of bilateral megaureter type 1A, where the terminal part of the ureter is dilated, but the rest of the ureteric course is normal, and the pelvic cell systems are normal. Sometimes you are confronted by this appearance, which is not common in the clinical practice, is known as megachelices. Megachelices means that the chelices are prominent. They are not showing the usual chelicial cupping, but there is no obstructive lesion. The renal parenchymal thickness is good. The renal function is good, and this is known as a congenital megachelicosis. Then we came to the calyceal diverticulum, which is similar to any diverticulum in the body, and it is a congenital outpouching of the renal calyx or the renal pelvis. And there are two types: type 1 with narrow neck, type 2 with wide neck. The diverticuli are lined by transitional epithelium similar to the pelvic calyceal system. They are seen in about 0.5% of the intravenous urograms and more common in females. The majority of diverticuli are asymptomatic, but sometimes they may result in hematuria. They are sites for stone formation, and hence they cause flank pain or recurrent UTI. Then in the IV beam, you can see this is type 1 calyceal diverticulum with narrow neck, and this is, you can say, this is type 2 calyceal diverticulum with a relatively wide neck. And here you got multiple radiopaque calculi in the right kidney. And on the intravenous urography, you can see that there is a cavity which is connected to the normally appearing calyces, and this cavity contains the stones. And this is the calyceal diverticulum with stones inside. Sometimes the calyceal diverticulum is exactly similar to the simple renal cyst. But if you wait for some time, then you can, in the delayed films, you got filling of the diverticulum with contrast material, while the renal cyst will not fill with contrast material. And this radio density seen in the non-contrast scans is due to the presence of some calcium within the diverticulum, which is known as the milk of calcium. And this is a plain film, then intravenous urography. In the initial intravenous urogram, you see displacement of the renal calyces as if there is a simple renal cyst here. But in the delayed films, and you got that this filling defect will fill with contrast material, indicating that it represents a ciliceal diverticulum. And diverticuli may be multiple and bilateral, as you can see in this particular case. Then we came to the stones, and you know, the stone disease is one of the common problems of the urinary system, and most of the stones are radio opaque and they contain calcium. Well, however, some of the stones are radiolucent, and the radio-opaque stones can be detected easily by the plain film, especially if they are large. And this is an example of multiple bilateral renal calculi, an example of multiple urinary bladder calculi. And this is one of the common appearance of the urinary bladder stones, which are large and lamellated, as you can see here. If the stone is radiolucent, it can be seen as a filling defect in the intravenous urogram. As you can see, this big stone filling the renal pelvis as well as the lower ball calyces. Sometimes in this is known as obstructed nephrogram. In patients with renal colic, it is better not to perform in the intravenous urogram because the kidney will not excrete the contrast material adequately. It will have some delay time to secrete contrast material, and it will show what's known as persistent nephrogram. On the opposite side, you can see the pelvic ileal system and ureter are good, but here the kidney is not able to evacuate the contrast material in the pelvic ileal system, and this is usually because there is an obstructing small stone along the course of the ureter. And here is another example where you can see that the left pelvic ileal system is good and the ureter is also good, but there is fullness of the right pelvic ileal system and a stasis of contrast material along the whole course of the ureter, which is not a usual finding. Then you may expect some pathology which prevents the ureter from adequate evacuation. And at that time, this pathology may be one of three. Either it is a stone or a stricture, or this may be due to reflux. And here is the plain film, and you cannot see calculi. The IVB using the digital tomosynthesis identified this calculus, which is further confirmed by CT scan to be located in the distal third of the ureter. And also this is one of the values of digital tomosynthesis where you can here you see fullness of the left pelvic ileal system and the proximal part of the ureter, but you are not able to identify calculi for sure. But in this tomosynthesis, you can see these minute calculi in the proximal third of the ureter. Also, this is the normal intravenous urogram here. This arrow points to a small ureteric stone, which is located at the terminal part of the right ureter. And that's why the right pelvic ileal system and the right ureter are filled by contrast material, and they appear relatively full compared to the opposite side. Then that's why I said we should have every time the plain film before injecting contrast material, because sometimes whenever you inject contrast material, the radio density of the contrast will obscure the detection of the stone. Then this is a distal ureteric stone obstructing the left ureter with consequent back pressure effect on the ureter and the kidney. Also, ultrasound is one of the good imaging modalities for evaluation of stones in the kidney, proximal ureter and distal ureter, but I think that the middle part of the ureter is difficult to be examined by ultrasound, as I feel. But here is a stone in the terminal part of the ureter with dilated ureter and dilated pelvic cell system. And then this in this intravenous urography, you may have some difficulties to identify where is the stone. But in the plain film, you can see this is the stone which is located here, and it causes no appreciable back pressure effect. Then, when I ask you about where is the stone in this intravenous urogram, and you may think that it is located here or there, but look in the plain film, there are two big staghorn stones in the kidneys that did not disturb the renal function and did not cause obstructive changes. And not only the small calculi that can be missed by contrast material, is also the big stones as well. And this patient with flank pain, and you see a small radio density here and another one here, they may represent flipuli, or one of them may represent a calculus. In intravenous urography, you can see that the ureter and the left kidney are showed some fullness down to this particular area. I think that this is the site of the stone, and here you can see this is the site of the impacted stone with normal caliber of the ureter distal to the stone. Then whenever you see this appearance by IVB, you think of one of three. This appearance is in the form of dilated collecting system, dilated ureter along its whole course. Then there should be something here, either a stone or a stricture, or it may be secondary to vesico-ureteric reflux. One of the best ways to evaluate this particular site is to have the CTUT, which is the non-contrast CT scan dedicated for evaluation of the urinary stones. And here you can see the radio bay calculus impacted in the terminal part of the ureter. Another example, and the early film by IVBs, and see good function of the left kidney with normal appearance of the left ureter, but you may feel that there is a stone here. And that's why in the delayed film you got fullness of the right pelvic cell system, dilatation of the right ureter, and tortuosity along its whole course. Then, whenever you are suspecting calculi in the urinary system, one of the best ways to check for these calculi is the CTUT, or the non-contrast CT examination of the urinary tract. This is an example of stone in upper ureter, another example of a stone in the lower ureter in another case. And then this patient, which who has been injected with contrast material, and you got some delayed function of the right kidney with dilatation of the renal pelvis. And if you go down to the urinary bladder, and you can see a stone which is impacted in the terminal part of the ureter, surrounded by some sort of ureteric edema. Then here in the CTUT, you see bilateral small renal calculi, and the more calculi are detected in the films, as well as a stone in the ureter. It's better, or let us say it's mandatory, to have these reconstructed images along the ureteric course for better evaluation of ureteric calculi. And if you look here and you see a small calculus, which is located on the right side of the pelvis, this is a CT urography. CT is obtained after injection of intravenous contrast material. You see the stone and mild back pressure effect on the right kidney, and also you can appreciate duplication of the left collecting system and the ureter. Then if you look here, you cannot see any radiopaque stones going down, no stones going down, no stones going down and there is a radio opaque shadow here. Then those who are used to interpret this CTUT know that this is not the course of the ureter. The course of the ureter is here, and this should represent a pelvic phlebolus. But if you have the reconstructed images along the ureter course, and you can see that this ureter contains no calculi, and also the right ureter contains no calculi. Then if you look here and you know that this is exactly the site of entrance of the ureter inside the urinary bladder, and there is a stone here. The reconstructed image easily appreciate the site of the stone and the dilatation or the back pressure effect on the ureter as well as in the collecting system. Finally, we came to the issue of nephrocalcinosis, which means that there are some increase in the blood calcium or in the calcium in the urine, which is deposited in the renal parenchyma in a fashion which is known as the nephrocalcinosis. The nephrocalcinosis is divided into three types. When calcium is deposited in the medulla, which is very common type, representing about 95% of the cases, medullary nephrocalcinosis. And a rare type, which is known as cortical nephrocalcinosis, where calcium is deposited in the renal cortex. And the combined type is more rare than the cortical type. Then if you look here and you see dense calcium in the renal parenchyma, in order to remember the causes of medullary nephrocalcinosis, you can remember these abbreviations: HAM, HOP, hyperparathyroidism, acidosis, medullary sponge kidney, the most common cause of medullary nephrocalcinosis, hypercalcemia and hypercalciuria, oxalosis, and papillary necrosis. And what is the medullary sponge kidney? This is a developmental defect affecting the formation of the collecting tubules, which will result in dysplastic, dilated medullary and the papillary portions of the collecting ducts. And because of the dilatation, there is somewhat a stasis of the urine in these ducts, which will predispose to deposition of calcium later on, and most of the cases develop medullary nephrocalcinosis. The incidence of medullary sponge kidney is about 1 every 5,000 cases, and most of the patients are asymptomatic. 10% of the cases may have UTI, urinary tract infection, stones, or hematuria. Then, because of the stasis of the contrast material in the dilated tubules, and you got this very characteristic appearance in the IVB, which is known as the bouquet of flowers or the paintbrush appearance. And you see it's very classic appearance of the medullary sponge kidney. And also this is a medullary sponge kidney where you got a staining of the ectatic tubules in the renal medulla, and giving this very characteristic striated appearance. Now, when calcium is deposited in the plain film, you can see calcium is deposited in the renal medulla, and by CT also you can see calcium deposited in the renal medulla. Then what is the renal papillary necrosis? This means that there is ischemia of the renal papilla, which is protruding into the calyceal cup, and this will result in necrosis and sloughing. After sloughing of the papilla, it will go into the collecting system. It may obstruct the ureter and may lead to flank pain, hematuria, and variable degrees of renal function abnormalities. Also, anuria or oliguria may be present in the advanced stages, And urinary stages may lead to pyelonephritis with fever and rigors. In order to remember the causes of renal papillary necrosis, you may remember this abbreviation, DINOSAUR. Diabetes mellitus infection like TB, non-steroidal anti-inflammatory drugs, analgesic abuse, sickle cell disease, urinary tract obstruction, and renal vein thrombosis. And these are the stages of renal papillary necrosis. This is the normal appearance of the papilla. If there is ischemia of the tip, there is protrusion of the contrast material inside the tip, which is known as pollen T. Then one of the appearances is known as also fornix excavation or the lobster claw or the signet ring or the clubbed calyx, like this one. But the most typical appearance on IVB is this one, which is known as pollen T, and this can be seen on the intravenous urography as the collection of contrast material within the renal papilla. And look carefully here, and you should see here celestial cupping, and this dot of contrast material is present inside the tip of the papilla. Another example here, and a third example here. This is diagnostic of renal papillary necrosis. Then cortical nephrocalcinosis means that you got calcification of the renal cortex. And to remember the causes of this abnormality, you can remember these abbreviations: COAG, cortical necrosis, oxalosis, Alport syndrome, and glomerulonephritis. What is Alport syndrome? Is the combination of sensory neural hearing loss, renal abnormalities, including renal cortical nephrocalcinosis, and sometimes ocular lesions. This is Alport syndrome, which is an X-linked disease. The kidneys may be shrunken with delayed or no contrast excretion in advanced stages. The patient may have leiomyomas in the esophagus or in the tracheobronchial tree or in the uterus. MRI may also show abnormalities in the white matter. And this is an example of cortical nephrocalcinosis by plain film. You see the cortex is calcified. By ultrasound, you see the dense or the echogenic renal cortex. And remember that there is no acoustic shadowing for this calcium present in the renal cortex. Another example, the left kidney is good, the right kidney is small with dense calcification of its cortex, diagnostic of renal cortical nephrocalcinosis. Another example of bilateral renal nephrocalcinosis by cortical nephrocalcinosis by CT. You see calcium is deposited in the renal cortex bilaterally. Thank you very much. Walhamdulillahi Rabbil Alameen.